Cool. So, final topic, robotic surgery. This is the shortest of the topics because it's mostly covered by the laparoscopy. So, robots, they're largely just an expensive toy. So, on the picture up on the right, on the left-hand side, you have the Da Vinci robot, which is the sort of most common robot that you're going to see. It's pretty much the only robot that's licensed, really. And then on the right-hand side, you've got a droid from Star Wars, a medical droid from Star Wars, and it just reminded me of that. But the Da Vinci are made for life, basically, because each of the instruments that attaches to the Da Vinci costs, I think, £10,000, and they are electronically coded so that you're only allowed to use them like 5 times before you have to throw them in the bin, and they get bricked and they're completely useless. So they're incredibly expensive, and when they've done Cochrane reviews and the like, they are only marginally, if at all, better outcomes for the patients. But they're kind of cool, and surgeons like them, and it allows the surgeon to be descrubbed, sat in a chair in the corner of the room, rather than stood up for like 3 hours doing a prostate. And as I mentioned earlier, one of the key benefits of them is that the claws at the end, the laparoscopic instruments at the end, have increased different ranges of motion. So they're more akin to actually having a miniature hand inside the abdomen, rather than just a stiff grasper as a normal laparoscopic instrument. If you get the chance to have a look at the surgical control box in the corner of the room, it's often quite cool to go and have a look through there, because they have 3D goggles so that they can see the abdomen in 3D as well. So from their perspective, they're sort of almost like standing in the middle of the abdomen with these sort of instruments as their actual hands. So it's a cool piece of kit, but it just doesn't really translate to better outcomes. And because it's a cool piece of kit, they're doing it for an increasing number of surgeries. So we use them for prostates, bladders, kidneys. But I've also heard of general surgeons wanting to try them out on hernias. You have some cardiothoracic surgeries doing them on thyroids and thymomas, because of the idea that you can sort of get behind the sternum with the increased maneuverability of the laparoscopic instruments. As well as sort of thoracic surgeries as well, because you can sort of get in between the ribs with these instruments. So yeah, one of the things to consider with robots. So positioning is always a problem with robots. So for example, for the prostate, they need really quite extreme head down. I'm talking sort of 35, 40 degrees head down. Now, this has issues where you can have increased risk of cerebral edema because you've got sort of increased intracranial pressure, which then increases your post-op confusion rate as well. And it can also result in the patients looking like little Michelin men because their faces swell up so much. So you need, sorry, that's not meant to say loose ties, but loose ties for your endotracheal tube. Otherwise, they can cut into the patient's face. You have increased chance of regurgitation. So it's not uncommon for you to sort of take the drapes down at the end of the procedure and the patient has effectively bile in their hair. So it's quite a good idea to stick an NG tube down for those. And it sort of exacerbates all of the issues that laparoscopy brings. Because as I said before, with the sort of like respiratory things, you've then got the weight of the abdominal organs also on your diaphragm, causing the same issues that the pneumoperitoneum does. One of the things that I think is probably underreported as well are traction injuries. So these patients are still in the lithotomy position, but because of their extreme head down, they quite often have quite a lot of weight on their calves, on in the stirrups. So it's quite common that you can get stretching of the sciatic nerve or compression of your common peroneal nerve within the stirrups. So it's one of those things that positioning is key, and making sure that the pressure areas are padded is also key. Because of all of that, as well as getting the patient in the correct position, getting the robot in the correct position, so on and so forth, the setup takes forever. So, for the, bladders, you probably won't actually have knife to skin until about 10:30 in the morning, even though you've started dead on 9. It's absurd. But that is what it is. One of the things to bear in mind is that you can't move the table after the robot has docked. When the robot docks and they put the instruments into the patient, the robot is in a specific position. If you start moving the table whilst the robot has got its instruments in, the robot will stay in the exact same position, and you'll basically just tear a hole through the patient's abdomen. So just don't touch the table controls, because the robot will win in that situation. One of the things to bear in mind is that it does take time to undock the robot if you're in an emergency. So, for example, if you've got a cardiac arrest on, the surgeon's just stuck something through the aorta and they need to convert to an open procedure, it will take precious minutes to get the robot out of the way. Relatively commonly, they have a sort of simulation in Eastbourne where they practice trying to get the robot off the patient quickly. But I think even at the quickest, it normally takes sort of 5 or 10 minutes. So it's just one of those things to make sure that you've got a decent sized cannula, and you anticipate that if there is an emergency, you won't necessarily be able to get access to the actual patient. So, any questions about robots? Nope. Good. So, in conclusion, you've got the urology procedures, quite a lot of them, quite a lot of done by elderly men, on elderly men, almost all in the lithotomy position. The vast majority of them can be done under simple GA, but you can also do them under regional. Laparoscopy is great, but it has its own considerations, both anaesthetically and surgically, and you need to be aware of them and have sort of high index of suspicion for things going wrong when you're doing a laparoscopic procedure. Robots are fun, they're cool, but they also have their own issues and they're incredibly expensive. I think that's about it, really.